First, I'll be giving a brief patient information. The patient name is EE. He is a 21 months old Duzon-raised male toddler with normal weight, height, BMI, and BSA. He had generalized tonic-clonic seizure at 8 a.m. on 29 February, which lasted for more than 30 minutes. Before this, he had fever, lethargy, and reduced oral intake, which he was brought to the GP and discharged with syrup paracetamol. He was brought again to GP during seizure, but there was no oxygen there, so he was brought to ED by ambulance. He still had seizure in ED. He had no family history of developmental delay, and this was his first hospitalization. His mom had anemia during her antenatal pregnancy, but he was born in term with normal birth weight. He had good developmental history on other aspects except for his speech ability, which was not on par with his age. His immunization is up to age with no additional vaccination. He had no past allergies and past medical problems. First day of admission, he was given IV diazepam and oxygen in view of status epilepticus with severe hypercapnia. He was then given IV phenytoin. At PICU, he was well sedated with good chest expansion but had multiple rash at cubital fossa. He was started with IV ceftriaxone and IV acyclovir. On the 1st of March, he was continued on lumbar puncture although he was not well sedated on IV midazolam and IV morphine. He was extubated and continued on antibiotic and maintenance phenytoin. On the 2nd of March, he was noted on increasing rashes and multiple blisters. His CSF results show negative bacterial and HSV virus. His CSF protein and glucose were found to be high. He was continued on maintenance phenytoin and given IV chlorpheniramine. He was off on acyclovir. On the 3rd of March, the patient was alert and playful with his rashes reducing in trend. He was noted to have speech delay and allergy to medication. His IV ceftriaxone and phenytoin dose were reduced. The highlighted readings show abnormal level of parameter of lab investigations. The patient had high fever on the first 2 days of admission, which then became normal on the 3rd and 4th day. The high WBC count and percentage indicate potential infection. The high MCV level indicate potential macrocystic anemia. He had normal renal profile and BUSE except for low potassium on the first day. He had low oxygen on the first day but high on the second day once intubated. The carbon dioxide level was high on both days but decreasing in trend, and he had normal input and output chart.
The next would be the diagnosis, which is status epilepticus. The patient experienced jerking movement, uprolling of eyeball, drooling of saliva, which are the symptoms of generalized tonic-clonic seizure. Since the seizure lasts for more than 30 minutes, based on pediatric protocol for addition, the treatment given should be IV diazepam 0.2 mg per kg, in this case 2 mg stat, followed by IV phenytoin 200 mg stat if patient develops seizure more than 5 minutes after diazepam initiation. However, the patient have not developed seizure after initiating diazepam, therefore phenytoin is not recommended for the prevention of recurrent seizure. Besides, the patient has no history of seizure, and the seizure might be provoked by the precipitating factor, which is fever. Therefore, it is recommended to treat precipitating factor. As such, the patient should be given antipyretic, paracetamol 60 mg TDS, and antibiotic for infection. So, the patient has 30% risk of recurrent seizure, which is low. For monitoring plan, we have to monitor the relapse of seizure. Besides, the patients on diazepam should be monitored on heart rate, respiratory rate, and BP. If the patient is on phenytoin, we should also monitor the sign and symptom of CNS toxicity, for example, ataxia and nystagmus. Thus, we will also monitor the albumin and electrolyte level.
The signs and symptoms of patient that support the diagnosis are fever, lethargy, poor oral intake, high white blood cell count, and also result from lumbar puncture, which shows high total protein and glucose in cerebral spinal fluid. According to pediatric protocol, there are many types of meninges and encephalitis, and it can also be determined by the infection whether it is from bacteria or virus. However, the result for bacterial culture from the lumbar puncture is negative for H. influenza, group B streptococcus, streptococcus pneumonia, E. coli, and N. meningitis. Therefore, we may suspect that it is caused by viral infection and require further investigation such as PCR testing, CT scan, or MRI. So, for the recommended treatment, the drug chosen is ceftriaxone. It is recommended because patient is more than 3 months old and it gives more rapid CSF sterilization as compared to cefotaxime and cefuroxime. However, once the infective organism has been identified, the antibiotic choice should be reviewed again. Next is acyclovir. Acyclovir should be initiated in patients with suspected encephalitis. or has pending result of diagnostic studies. Other empirical antimicrobial agents should be initiated, including appropriate therapy for presumed bacterial meningitis. In this case, the antimicrobial agent used is ceftriaxone. Lastly, monitoring of drug therapy. For ceftriaxone, monitor sign and symptom of infection such as temperature and white blood cell count. Next, monitor CSF culture, glucose, and protein. Monitor albumin level as ceftriaxone is a highly protein-bound drug. And monitor sign and symptom of anaphylaxis as patient has a complaint of allergic to medication. For acyclovir, monitor for rash, pruritus, and urticaria. Monitor for inflammation, phlebitis at the site of injection. Monitor for neurotoxicity such as tremor, lethargy, impaired consciousness, and also nephrotoxicity such as burn, creatinine, urea, sodium, potassium, ion level, and urine output. And lastly, monitor liver function tests such as ALT, ALP, and AST.
Let us start with the first drug-related problem. Allergic reactions such as the rash and the blister experienced by the patient may be due to the medications such as acyclovir, ceftriaxone, or phenytoin. For the management, first we can immediately discontinue the responsible drug. Then for the IgE-mediated mild reaction, we can give antihistaminic drug. Then additional treatment can be given if the non-IgE-mediated reaction does not resolve after discontinuing the drug. Then for the sign of anaphylaxis, we can give epinephrine. Graded challenge can be conducted so that we can identify the drug that is responsible for the allergic reaction. Drug desensitization can be carried out when there is no available alternative. Lastly, when selecting alternative, we can aware of the cross-reactivity and the dosage form of the medication. For monitoring, first we can monitor the rash severity and distribution through observation, then the itchiness. Lastly, monitor if there is any presence of discharge from blister. The second problem identified would be the suitability of on-label use of chlorpheniramine for children under 2 years. This is because longer seizure duration is observed in patients receiving the first generation antihistamine. Then usage in infants also can potentially disturb the decomposite central histaminergic system. Then induction of neuronal excitability and a lower seizure threshold in vulnerable patients, since both mechanisms controlled by the central histaminergic neurons. Maximum recommended dose under 2 years is 1 mg BD, but patients receiving 1 mg STAT then 1 mg TDS. Next, the central nervous effect makes it unsuitable for patients with febrile seizure. For the management, because the sedating antihistamine is associated with the lower seizure threshold, therefore we suggest the newer, less sedating antihistamines, which is the cetirizine. For the monitoring, we will monitor whether the rash have any improvement or not. Next, we will monitor the common side effects of the cetirizine, such as the diarrhea or cold-like symptoms that are more likely experienced by the child.
For the next drug-related problem, patients should not be on maintenance dose of anti-epileptics once seizure is resolved. This is according to Pediatric Protocol 4th edition. Patients should not be recommended for prevention of recurrent febrile seizure and should be given antibiotic instead. If the patient has high risk of developing recurrent seizure, rectal diazepam is applied. However, in this patient, the risk factor is low as the degree of fever is low and the duration of seizure is less than 1 hour. If there is evidence of risks more than benefits, anti-epileptic treatment should be considered if the patient has second time of seizure. And then if the patient is seizure-free for 2 years, we can consider to withdraw the medication. However, patients might be developing cognitive and behavioral adverse effect, hypersensitivity reaction, and psychiatric adverse effect which may affect the developmental milestone of the patients. For the management, we can discontinue the phenytoin by slowly tapering down the dose of phenytoin to 0. The next directed problem, the CSF sampling time is incorrect. The lumbar puncture was done on March 1st after antibiotics initiated on February 29th, which might affect the CSF culture result. According to the Nambia Standard Treatment Guideline, CSF sampling should be done prior to the initiation of ceftriaxone for empirical purpose. The goal of therapy is to initiate the empirical antibiotic therapy within 60 minutes of patient arrival in the emergency room. The CSF should be obtained for culture and empirical antibiotic therapy initiated without delay. On the other hand, if there is a delay in obtaining CSF culture, such in situation where CT scan is done first that need antibiotic to be initiated immediately, lumbar puncture can still be done within 4 hours after initiating antibiotic. According to a study, 73% of patients who underwent a lumbar puncture within 4 hours after starting antibiotic had positive culture. Beyond 4 hours, the chance of positive culture drops significantly.
Next, there was drug-drug interaction between chlorpheniramine and phenytoin. It was suggested that chlorpheniramine will inhibit hepatic metabolism of phenytoin, which increased serum level of phenytoin and eventually may cause phenytoin toxicity. We suggest to monitor closely and change chlorpheniramine to other non-sedating antihistamine that will not interact with phenytoin and with lower risk of precipitating febrile seizure. We need to monitor the serum level of phenytoin and the symptom of phenytoin toxicity, like serum level higher than 30 mg per liter, experience of ataxia, hyperreflexia, nystagmus, and tremor. Last but not least, the child may have speech problem where he only able to say a single word. According to pediatric protocol, he is supposed to be able to use 50 words and 2 to 3 word phrases at his age. This condition may due to encephalitis, causing him to have trouble to talk and speech change. We may refer him for speech therapy to regain his speech scale and monitor whether there is improvement after therapy and encephalitis resolve. Thank you for watching.